Okay, now we're going to finish up this assessment of the heart, focusing on a couple of last few things. Now, we were talking about the different extra heart sounds and what to look for when we are auscultating the patient. Now, there were just a couple more that, and these are not all incomplete. These are just in general some of the ones that we do listen to, but there are a ton of different types of sounds that we can hear. And I know that we spoke about increased S3, increased S4, having spoken about how it sounds like Kentucky, Kentucky, whenever we have an increased S3. And then on the other hand, we have an increased S4 that sounds like Tennessee, Tennessee. So we see how the patterns change there when you hear the beats. When the Tennessee, you hear that S4 comes a little bit later, and the Kentucky is a little bit quicker after S2. So we've already gone through that. There was another 3 different things that I wanted to go over when you're auscultating the patient. You want to make sure that you know what a mitral valve opening snap is. Now this is a high-pitched snap that you hear. And you actually listen to it at the second intercostal space. That is the best way to hear it with your stethoscope. So you want to go ahead and place your stethoscope on and use your diaphragm and place it medial to the apex at the second intercostal space right here. And then you just listen to that high snap of the mitral valve. In this case, we cannot hear it, but this is where you would listen for it. And then you also have something that you call an ejection click. Now, ejection click is auscultated also with the diaphragm, and you can have the patient for any of these in any seated or supine position. And you also want to hear this one, but this one would best be heard here at the apex of the heart. And then the last one that I wanted to go over was pericardial friction rub. This is very, very important because if you have inflammation of the pericardium, this is what you would hear. And so when you hear this, you would hear, just like when we were talking about the lungs, how you hear grating, dry rubbing sound. This is the same thing. You would hear this grating, rubbing sound, and it's best heard at the apex of the heart as well. Now, it's very, very important that we hear for these heart murmurs, and we give it enough time to actually auscultate them. And you want to know whether what period of the cardiac cycle that they're occurring in, so that you can detect what kind of murmur it is. Now, there are different things that you want to look for when hearing a murmur. If you locate or you're able to hear a murmur, you want to make sure that you time it and you see how long it lasts. You want to listen to the pitch of it, if it's a high pitch, a medium pitch, or a low pitch, because that could pretty much describe to you what kind of murmur it is and what it is actually affecting. The intensity, now that is normally on a scale of 1 to 6, 1 being that you can barely even hear it, and then the 6 would be one where you could actually put your hand on it and you could feel that thrill, and it's palpable, and you can actually look at it and actually see it visibly. You also want to see the pattern of the murmur, whether you have states that are crescendo to crescendo or plateau, and you also want to see the quality of that murmur, which would be somewhat like is it like when we're talking about the pericardial friction rub, is it raspy, is it rubbing, is it blowing, what kind of murmur is it? Now, we also want to identify the location of it. If it's on the base of the heart or the apex of the heart where it is heard better. Also, if it's radiating, if the sound is radiating, you want to follow that sound with your stethoscope and see if and determine whether it actually is causing different effects anywhere else. And you also want to note its radiation up to the carotid area, or maybe to the axillae. That'll help you define better what kind of murmur it is. And then lastly, want to see if it has any effect, if the respirations have any effect on it. Such as when we were dealing right now with the splitting of the S2 when we inhale deeply. Sometimes we can actually have a split in S1. Although uncommon, sometimes we may hear that we do have a splitting of the S1 when we breathe deeply in as well. However, that is normal. So different types of things that we need to look for, and sometimes we don't give the cardiovascular assessment and auscultation portion enough time to actually realize certain murmurs, because you definitely need to hear out for them, especially in hospitals when there's so many people around you and you're trying to hear with your diaphragm. It is very hard to kind of dismiss all those other sounds to try and hear for these things, especially when they are hardly able to be heard, such as in the case of a grade 1 type of heart murmur. So in that cases, I mean, sometimes, very many times we miss these things, but that pretty much completes the heart assessment. Thank you for watching, and we'll see you soon.